She is IRCF certified BLS and CCLS instructor. She has AHA certified BLS and ACLS instructor. She has more than 60 publications in national and international journals with 6 chapters in book, and she is a reviewer of many index journals. Her area of interest are resuscitation, airway, obstetric anesthesia, and perioperative care. Over to you, Dr. Rashmi.
Good morning, everyone. I am Dr. Rashmi Salhotra, professor at UCMS and GTB Hospital. Today, I will be talking about pre-medication in pediatric patients. Today's talk would focus upon definition of pre-medication and its need, enumeration of the goals of pre-medication, describe the benefit of pre-medication in pediatric age group, discuss the present context of giving pre-medication, classify the pharmacological agents used for pre-medication, and mention the various routes, dose, onset, and mechanism of action. So first of all, coming on to the definition, pre-medication is administration of medication before any treatment or procedure, especially the surgery. Commonly, it is used prior to anesthesia for surgery, but may also be used prior to chemotherapy. The choice of pre-medication would be dependent upon the plan during PSC, and from the PSC onwards, the anesthesiologist should try and build a rapport with the parents as well as the child so that the induction and the reversal process and the entire perioperative process is a smooth one. Traditionally, pre-medication was given to counteract the adverse effects of the anesthetic agents in common use at that time, which were ether and chloroform, and the most common route was the IM route because variety of drugs and different kind of routes were not available. So the disadvantage was pain on injection and bleeding disorders. If the patient had, then they would land up into severe problems. Present day, since we do not use these anesthetic agents, and whatever formulations we are using have a fast onset, be it IV formulation or even if the vein is not available, then we use sevoflurane for induction. So both these types of techniques can have an onset within 1 minute. And secondly, there is requirement of patient surveillance and monitoring the vital signs because of the potential side effects of the agents which are used for pre-medication. So more manpower is required, and that will increase the cost of the entire burden of the disease. Then timing of pre-medication is also important because sometimes the unwanted effects are sometimes the desired effects are not achieved if the case is taken up earlier than it was presumed to be. Then the pre-medication would take its effect. Or sometimes the surgeries are delayed because of high burden on the centers. So the timing of pre-medication is very important, and because we cannot anticipate the exact time of giving anesthesia, therefore, the usefulness or the efficacy of pre-medication is doubtful. Most of the procedures these days are done as outpatient procedures. So in case the sedative pre-medication delays the recovery, then also it mars the purpose of giving pre-medication. However, preoperative anxiety, which is a very unpleasant experience for the patient, needs to be curbed. The anxiety may arise from the fear of surgery, and this will result in a stormy induction, emergence delirium, and greater postoperative pain in the patient. Not only that, the patients can have long-term behavioral impact. So, like they can have new onset enuresis, they can be aggressive or develop eating disorders in the post-op period. So, these patients require preoperative medication. The goals traditionally of pre-medication were anxiolysis, analgesia, amnesia, anti-emesis, anti-sialagogue, and anti-autonomic or vagolytic, which are known as the 6 A's of pre-medication. Aside from that, a pre-medicant drug should provide a tranquil and well-rested patient, decrease the hazards incurred by anesthesia and surgery, prevent postoperative pain, decrease perioperative shivering and pruritus, prevent allergic reactions, and suppress the reflex responses to surgical stimuli, and decrease the anesthetic requirement for the surgical procedure. And besides the pre-medicant drugs that we can use, I will come to that later on. But the very important requirement is of the adjuvant techniques that help in the initial part of the parental separation and gaining the trust of the anesthesiologist. So these include gentle rocking and soothing voices or use of soothers, but they are effective only up to a 9-month-old child. With an elder child, especially those with 1 to 3-year-old, these patients will have a lot of separation anxiety from the parents. So the parental presence during induction helps. For elder children between 3 to 6-year-old child, distraction techniques like use of mobile phones or toys or stories in the perioperative area will help them gain the trust of the anesthesiologist, and they can move to the OT without much fuss. Preoperative play therapy with the use of videos, pamphlets, interactive computer applications are helpful in a 6 to 12-year-old child. Behavioral interventions are very important in teenage and elderly children because you can involve them in the patient care. So preoperative hospital tours, videos, pamphlets, and interactive computer apps can help with this. And music and non-aggressive lighting will go a long way in calming and soothing the patient. Then coming on to the pharmacological agents, there can be various classes of pharmacological agents, which we will be discussing one by one. However, it is very important to know what are the routes of administration of these pharmacological agents. You can give them through injectable routes, but they are invasive and painful, so not acceptable by children. So sometimes you will need to apply EMLA cream before giving injections, if that is the only route available. However, it is not preferred as a pre-medication route any longer. Other routes are oral. They are well accepted, but the bioavailability of drugs may be low. Sometimes the patients may even spit or vomit after the oral drugs. Rectal can be painful and they may cause expulsion in children, young children, and they may be inappropriate for older children. Transmucosal is a very effective route. However, burning and nasal irritation can occur. Sneezing or coughing can also occur. But the advantage of the route is that there is an ability to bypass the first pass metabolism. Hence, the absorption rate, the bioavailability is high. Another route is inhalation of nebulized drug, which can be used for dexmedetomidine, ketamine, and midazolam. Now coming on to the specific agents one by one. Benzodiazepines are a very important class of agent, and they cause hypnosis, sedation, anxiolysis, anterograde amnesia, vagolysis, sympathicolysis, and reduction of PONV without any effect on the retrograde memory. They act by the agonism of the GABA A receptor, which is an inhibitory neurotransmitter in the brain, and hence it soothes or calms the patient. The most common drug used here is midazolam, which is a short-acting drug. Lorazepam and temazepam are intermediate-acting, and diazepam is a long-acting premedicant. They can be given through oral, nasal, rectal, or IV route. The dose will vary as per the route used. But the disadvantage is that it can have prolonged effect and paradoxical responses in some patients. Coming on to the opioids, they are good for providing analgesia and sedation. They act by mu, kappa, and delta receptor agonism. The commonly used drugs are fentanyl, butorphanol, buprenorphine, and traditionally morphine was also used. They can be used by any of the routes discussed previously, and side effects are dysphoria and nausea vomiting, which can be very disturbing at times. Transmucosal formulation of fentanyl is available, which is known as the OTFC or fentanyl lollipops. The advantage was elimination of first pass hepatic metabolism, but the onset is slow. and onset is short, but it may increase the gastric fluid volume. The dose is 5 to 20 microgram per kilogram, and advantage is post-op analgesia. Side effects are perioperative emesis, pruritus, oversedation, and respiratory depression. And this drug, this formulation did not gain a lot of popularity. Another class of drugs is the phencyclidines, including ketamine. They produce sedation and analgesia, and since the reflexes are not altered much, so it is safe in the out of OT settings. Mechanism is by NMDA receptor antagonism, and the very important advantage is that it reduces the development of chronic post-surgical pain. Can be given practically through any of the routes described, and the dosage can vary depending upon the route used. But a major disadvantage was hypersecretion, hypertension, tachycardia, emergence reaction, hallucinations, and illusions. However, children may seem to be less prone to this effect, and to avoid these or lessen these effects, they can be combined with benzodiazepines and antipsychotics. Another important class is the alpha-2 adrenergic receptor agonism, which produces sedation, anxiolysis, hypnosis, analgesia, improves the hemodynamic stability, sympathizes, and reduces the anesthetic requirement. The drugs include clonidine and dexmedetomidine. Oral clonidine dosage ranges from 2 to 4 microgram per kilogram and can be used via the intranasal or intravenous route as well. It is very useful in children with past history of delirium, agitation, or paradoxical reactions to midazolam. So you cannot use midazolam in those patients. So that places you can use clonidine. The added advantage is that it suppresses the neuroendocrine stress response as well. Dexmedetomidine can also be given, but the disadvantages are hypotension, bradycardia, and dry mouth. Anticholinergics were historically used, as previously stated also, with ether anesthesia and in surgeries where the vagal stimulation is anticipated. So, as in airway instrumentation, nasopharyngeal stimulation, and use of anesthetic drugs, particularly halothane and morphine. However, nowadays, since we are not using all these halothane and morphine, so the need to administer the anticholinergics as a routine agent has gone down. These drugs include atropine and glycopyrrolate. Atropine has the disadvantages of temperature elevation, flushing, dry mouth, tachycardia, and CNS irritability, together constituting the central anticholinergic syndrome. However, glycopyrrolate could be used safely in place of atropine since it's a quaternary ammonium complex and does not cause the blood-brain barrier, so has minimal CNS effects. It also causes less of tachycardia. The advantage is reduction in the gastric volume and alteration of its pH. Next important class of drugs which can be used as premedicants or intraoperatively are antiemetics, which include the antihistamines and the prokinetic agents. They are useful in concomitant use of opioid premedication, where you anticipate high PONV, as in GI emergencies, trauma, full stomach, squint surgery, or ear surgery, etc. Giving a multimodal type of therapy, like including a lot of drugs, a lot of antiemetics from different, 2 or more antiemetics from different class of drugs, rather than increasing the dose of a single antiemetic agent, is shown to be more effective. H2 blockers can be given orally. To reduce the acidity of the gastric contents in anticipation. So these can include oral non-particulate antacids like sodium citrate or oral ranitidine. Anti-shivering agents are very important because shivering is a very frequently known postoperative complication, which may range from the incidence may range from 40 to 64%. and it increases the oxygen consumption and causes an unpleasant feeling among the patient. So anti-shivering agents like mepridine, tramadol, nicopam, ketamine, dexmedetomidine, clonidine, magnesium sulfate, dexamethasone, and fentanyl may be used. Antipruritus agents. These are very helpful in patients who are receiving concomitant opioids, especially neuroaxial opioids, as pruritus is seen with an incidence of 30 to 100% in these patients. So 5-HT3 receptor antagonist, opioid antagonist, antihistamines, NSAIDs, and droperidol are effective agents to reduce pruritus. Another agent that can be used is melatonin, which produces hypnosis, anxiolysis, sedation, and anti-inflammatory action. It produces a natural quality sleep and hence may reduce the incidence of emergence agitation. Chloral hydrate and triclophos were also used quite a number of times. Triclophos has a better palatability and less gastric irritation, and it is the active metabolite of chloral hydrate. But they are not recommended in neonates and patients with liver disease, as that is the place of the metabolism. With this, we come to the end of today's talk, and I would like to conclude by saying that parental and patient involvement in the perioperative period will help in building up the trust and will provide a reduction in the anxiety and a calm patient in the preoperative area. Pain from injections and needles should be avoided, so at all costs. The more the number of hospitalization, the more is the requirement of the pre-medicant drug. So such patients should be treated with utmost care, and they should be given a lot of attention while giving pre-medication. The effects on the pre-medicant drug may vary among patients, and so the doses should need to be tailor-made. Sedative pre-medications should be given only if monitoring and oxygen therapy can be supplemented. So with this, I come to the end of my talk, and I hope that after listening to this, you would be able to decide and provide a calm patient like this one rather than a crying and a hyper irritable child in the pre-op area. So you're all welcome to ask questions now. Thank you so much for a patient listening.
Thank you, Dr. Rashmi. It was a well-covered presentation. We'll take up questions at the end of both the speakers.
Okay, thank you.
Coming on to the next session,